Hey everybody, it's Dr. Charles Modlin, your friendly urologist. I'm here with another Health Equity Brief. As a reminder, these Health Equity Briefs are an opportunity for me, Dr. Charles Modlin, urologist, kidney transplant surgeon, health equity champion, to provide you, the listening audience, with information that I believe is important for you, your family, and community to maintain and improve your health. So, we all know that September is, as urologists, we know that September is Prostate Cancer Awareness Month, and even though this is not September right now, I believe that every day should be Prostate Cancer Awareness Day. And just real quickly, I know I've done a Health Equity Brief previously on the subject matter of health disparities in prostate cancer in Black males, but I just want to relate some very important information and keep this at top of mind. So African American males, Black males, have a higher incidence of prostate cancer, higher death rate. In fact, Black men develop prostate cancer twice as often as their white male counterparts and have twice the death rates approximately compared to their white male counterparts. A lot of that is due to a delayed presentation and diagnosis because prostate cancer can potentially be 100% curable in Blacks and Whites. But a lot of times, oftentimes, the cancer is more advanced. It's not localized. It's more advanced outside of the prostate in Black men due to a delayed diagnosis. Now, why would Black men be more likely to have a delayed diagnosis? A lot of times it may be due to social determinants of health, lack of access to health care, lack of health insurance, lack of knowledge and awareness about the importance of screening for prostate cancer. So we need to do more to inform the community about the importance of screening for prostate cancer. Now listen up, here's some major differences where there are different screening recommendations based on the race of the individual with respect to prostate cancer in Black men. So Black men, because as I said, have a higher incidence and higher death rate than their white male counterparts, the recommendation from the American Urologic Association is that Black men should start screening for prostate cancer at the age of 40 years old. 40 years old, start screening for prostate cancer. Whereas white men don't have to start screening until age 55. That's a 15-year differential because of the higher incidence of prostate cancer and death rate in Black men. If white men have a family history of prostate cancer, then the recommendation that they should start screening earlier as well. That's an example of screening recommendations based on race. So race does matter. Whatever the definition of race is as we know it, race does matter in certain respects. And that just highlights the dissertation and talk I gave and posted online about the importance of diversity, equity, inclusion in medicine. This is just one stark example. So what are the ways in which to screen for prostate cancer? Before I get into that, first of all, you don't have to have any symptoms to have prostate cancer. You don't have to have any pain, discomfort. Most cases of prostate cancer, as a matter of fact, are diagnosed in men who have absolutely no symptoms. You could have symptoms of increased urinary frequency, getting up at night, incomplete voiding, but you don't have to have any signs or symptoms. So that just underscores the importance of getting routine preventative health screenings. I've always said that every man needs a urologist in addition to a primary care provider. It's true, your primary care provider can perform the screenings. Typically in the past, we had to screen with what was called a digital rectal examination. Nowadays, by and large, we can perform a simple blood test called a PSA. That stands for prostate specific antigen, simple blood test. So you don't have to be fearful, guys, of coming in and getting that digital rectal examination. Get a simple blood test. Now, what is considered a normal PSA? It's important to inform the audience that there is no one set normal value for what is considered a normal PSA in screening for prostate cancer. It depends on the decade of life in which you're in, your age. It depends on your race. So that's why I say it's important to have a urologist, because we have expertise in the interpretation of the PSA blood test, diagnosis, and treating prostate cancer. Historically, it used to be said that 4.0 or less was normal. that is not a valid assertion in terms of what is a normal PSA. So, for example, if you're in your 40s, African American males, the PSA should not be higher than 2.5. If you're in your 50s, the general recommendation, the normal PSA should be 3.0 or less. If you're in your 60s, 4.0 or less. And again, it's variable according to the patient. It depends on how quickly the PSA is rising. So every man should have a urologist. Every man needs a urologist in addition to a primary care provider. So PSA is a screening test. It does not diagnose prostate cancer. If you have an elevated PSA test, sometimes the urologist will repeat the PSA. There are other reasons for having an elevated PSA other than prostate cancer. You may just have a benign enlargement of the prostate. As you get older, that prostate enlarges. PSA is an enzyme produced by the prostate, released into the bloodstream, detected by the blood test. So you may have prostatitis, chronic infection, chronic inflammation of the prostate, a urinary tract infection, if you had any recent manipulation of the prostate, colonoscopy. All of these things can actually lead to an elevation of the PSA, which is not necessarily related to prostate cancer. So if you have an elevated PSA, as I said, the urologist may repeat it, will make a determination in terms of whether or not that given individual should undergo what we call a prostate biopsy. There are various ways in which to perform a prostate biopsy. Sometime we'll perform ancillary tests, an MRI of the prostate, for example. So the workup is variable according to the patient, according to the PSA level. Sometimes, as I said, we'll just repeat the PSA prior to recommending a prostate biopsy. Prostate biopsy generally is done as an outpatient procedure, very quick. There are potential risk factors or complications for getting a prostate biopsy. You can have some mild pain, discomfort, bleeding. Some of these biopsies are performed under anesthesia. Some are performed in the office. My major message of the day for you men out there: try to know what your family history, your personal family history is. Also, prostate cancer has a hereditary component. It doesn't mean that your father, brother, uncle, grandfather necessarily had prostate cancer for you to get prostate cancer, but there is a strong genetic hereditary component as well. Take-home message: you don't have to have any signs, symptoms. Get a PSA. The frequency to which you will get that PSA blood test is variable according to the patient. Some individuals will get it once every year. Another thing, and I'll talk about this in more detail in another health equity brief, but there are different grades of prostate cancer. There are different severities, aggressiveness, behavior of prostate cancer. An important point: not every man diagnosed with prostate cancer requires treatment. Some individuals can be on what we call active surveillance, watchful waiting. Some men are treated with radiation therapy, some men are treated with surgery, some men are treated with hormonal therapy. But this has been Dr. Charles Modlin with a Health Equity Brief. Every day is Prostate Cancer Awareness Day. Every man needs a urologist in addition to a primary care provider. Please like, share, subscribe, spread this information widely. Everyone can be a caregiver. Everyone can save lives by spreading important information that individuals in the community need to know. So until next time, I'm Dr. Charles Modlin, urologist, kidney transplant surgeon, healthcare advocate. I'll see you on this next Health Equity Brief. Thank you for being here. Stay safe.